I'm really delighted that our first speaker is Professor Paul Fortan, and he's at Laval University in Quebec City in Canada. And he's an international expert in APS and also in lupus, and he and I are involved in a large international lupus collaboration together. He's done a lot of work on patient access and information and quality of life, etc., across a number of rheumatic diseases. So he's going to give us a talk today about APS and its origins. Thank you.
Thank you, Ian. Thank you, Baroness Morris. Thank you, everyone, for being this morning. As you see, I'm from Canada. I have a Canada Research Chair, and one of the main aspects of this is to improve quality of life on patients with chronic systemic autoimmune diseases. I have interest in lupus and in the Anti-Phospholipid Syndrome. The task I've been asked to was to talk about what causes APS and whether I can pass it on. I'd like to add also that a patient day like this, for me, brings relevance to an international meeting like this one. And there has been precedent in lupus and in Canada in most of the rheumatic diseases now. We do have participation from the patients. And one of the considerations is actually patients coming to all of the scientific sessions and asking their questions in their own words. And this is quite challenging usually to the clinicians and to the researchers, but it does bring that dialogue into a really active form. So let's go on. I have no conflicts of interest. I wanted to have a quick survey. Who is actually from Manchester here? Okay. And the rest of the UK? Yeah, obviously. Is there anyone from outside the UK? Wonderful. So welcome. I think it's quite important. I'm going to go into the topic now. And one of the reasons why I asked for who's from Manchester is, well, first, what causes APS? Well, obviously, I wish I knew the answer so that we could move on and get really ahead. But as you know, this is a very difficult question to answer. So we're going to try to get some pieces of the puzzles this morning. But the plan I would like to follow today is the path to autoimmunity. And the reason why I asked about Manchester is yesterday I went to the evening at the Museum of Industry. And I think I discovered first that people from Manchester are called Mancunians. I was wondering why, and this is from the old Latin word for what was Manchester. But there's a link to that first part, the path to immunity, that I will bring on in a moment with Manchester, actually. APS, the syndrome. This is a syndrome, as opposed to, we'll review what that means. And what causes the manifestation of APS? I'd like to talk about the cards you're given, and I'd like also to talk about the chains and contours you make in your life, and what it's relevant to APS. And finally, why I should not test my children for APS if I have APS. And then I have a few slides on the rest of the day for my own suggestions to you on a dialogue. So the link to Manchester is really that I've been using this analogy for the past a few years since that movie that came on. Who saw The Imitation Game here? Yeah, a few people, right? And this is the story of Alan Turing. And Alan Turing was actually a scientist who finished his career here in Manchester. And yesterday I saw the Enigma machine, which I was very good about. Why am I bringing this up for APS? Well, he says that behind every code is an enigma. And in fact, there is actually the whole story in the movie that we hear about how he was able to decipher the codes the Germans were sending privately to their own allies to try to understand where, for example, submarines were, and they could prevent attacks from submarines. But the whole idea, I think, is relevant to autoimmunity. And why is that? Where I think we can start with the enigma. So there's questions we're asking, what causes autoimmunity? What causes APS? And there's all of this code that we don't know about. And somewhere there has to be a key that maybe will help us understand the code. And finally, what is the message sent here? So the enigma machines could reveal a secret message from coded text and a unique key. So for us, we know that we start with maybe some genes, some predisposing genes, but something else probably happens in the environment. We describe APS, like lupus, like a lot of our diseases, as complex disease, meaning that there's not only one, there are many pathways that could bring to this autoimmunity that will lead to APS. So the first thing, though, that happens in autoimmunity is that we have a loss of tolerance to self-antigens. So normally our immune system will not react against anything that we have inside our own body with our own cells. But one of the mechanisms that happens first is that there is an ability to lose this tolerance in people that are predisposed for that. That will bring the production of autoantibodies. You must have heard about autoantibodies in APS, these famous antiphospholipid antibodies in the case of APS. And eventually, this will lead to clinical disease. But there seems to be a process over time. It's not an automatic happening that once you develop the antibodies, you automatically develop the disease. There's a process. So I think this is quite relevant because, in fact, what we could see here is that we have a code that we don't know what brings on this loss of tolerance to nuclear antigens. Maybe by studying at least one of the things we can measure with these autoantibodies, we could get the key to understanding the early events that will lead to the disease. And what we really see in our practice as clinicians is the clinical disease. But once we see someone with a diagnosis of APS, all of these events here have already occurred, and we have to go back in time, which is a very difficult thing to do when you do research. So the other thing I want to say is that some of these things here are actually unknown because they don't manifest themselves by a clinical manifestation. So they might be going on for many, many years. Then there will be an onset of clinical disease. There will be disease activity. So in the case of APS, it will often present either with a traumatic event or a pregnancy event. And this could lead to some ongoing scarring or some events that afterwards is over. The problem we have is that we start here, and really what we have to go is try to go back in time to try to trace back what causes this manifestation. So the other challenge we have is that what we know is the case descriptions. We're very good at describing what has happened in a population of patients with APS, but the studies that actually go to the preclinical areas are few, and certainly our technology now allows us to go backward in time, but it's not perfect, and we have a lot of researching to do to get this evidence. So I'm going to go with the example of lupus just to illustrate one thing, which is in lupus there is a seminal study that was published in the early 2000s in the US. And what they've done is they had access to a bank of serum from the US Army. And every year these Army men or women, mostly men, had bloods that were drawn and were stored. And then after several years they went back and they looked at who had developed lupus out of these hundreds of thousands of people. Here on this graph, if you look at time 0 here, is the time of the diagnosis of lupus. And then they went back, and every year they pulled out the serum of these patients, and they actually tested them to see if they had any markers for lupus even before they knew they had lupus or before they knew they had any clinical manifestations. And this goes back to 5 years, but in fact it can even go back further. And what we see here are, in different colors are different autoantibodies. So in APS, the characteristic is having an antiphospholipid antibodies. But in lupus, you have several kinds of antibodies, usually towards the nucleus of the cell, so they're called anti-nuclear antibodies. And what they could see is that even 5 years before the diagnosis, up to 60 to 70% of people had several types of autoantibody that were already detectable. And as they went on, they accumulated a certain number of autoantibodies up to the moment of diagnosis. But what I'd like to point out here is that this APL, so this is the antiphospholipid antibody, and this is already present in the majority of the people, even 5 years beyond that. So I think we can transpose that these antibodies are likely to be present even before people present with lupus, and probably also in antiphospholipid antibody syndrome. So if we were to understand better what produces these autoantibodies, maybe that could be a key towards getting to the code. So why is there hype about autoantibodies? Well, they're very, very interesting little engineering machine that nature came up with to defend ourselves against infections most often, most of it. The antibodies are usually made up of a structure that will adapt and change according to the response they have to an antigen, to an environment, usually a protein. In phospholipid, it's a protein phospholipid complex, but these antigens can vary. So that's why when we talk about antiphospholipid antibodies, you may have noticed some people will have one kind, which could be the anticardiolipin. Well, that's one kind of antigen. But then you can change, you can have an anti-beta-2 glycoprotein one or lupus anticoagulant. But the idea is just that it is an antibody and it's just the little piece here that changes, but that could react to the environment. And the difference between the antibodies that are seen in the autoimmune diseases is that instead of being directed against a virus or a bacteria, which is the normal response of the immune system when it produces antibodies, it will react to components of our own cells. That's where the abnormality lies. And in most people, we probably have the capacity to do autoantibodies after an infection or after some type of stimuli, but our immune system will be geared up to eliminate the cells that produce the autoantibodies because there's a potential risk that they could cause disease. But in some proportion of the population, there is a predisposition to keep making these autoantibodies abnormally. That's where the abnormality lies. So they may be the key to the secret codes. And what is most important, if you remember my graph, is once they are associated with clinical disease. That also means that there are some people that will have antibodies detectable all of their life and may never develop manifestations. And that's another area we don't understand very well. So what are the different manifestations? We've seen blood clots, pregnancy problems, but there are other things, right, that have been described. Low platelet count, marbling of the skin, we call it livido, skin ulcers, neurologic-like disease, migraines, and kidney disease. So let's move on now to the syndrome, APS, the syndrome. Well, first you look at the definition of syndrome. It's a set of medical signs and symptoms and a collection of diseases which are not correlated with each other. So for example, someone may have a blood clot, someone may have a pregnancy problem. They're very different conditions, but yet they're all associated with the presence of this antiphospholipid antibody. So they may not be correlated with each other, and often they're associated with particular disease or disorder. It comes from this Greek origin of concurrence. So you have a concurrence of an antibody that is associated with phospholipid and some clinical manifestation that tends to be the same and that are recurring. So we have a syndrome, but it's not a single disease like you would have with cystic fibrosis, for example, where you can go back to one gene and you know exactly what it's going to give you. So the antiphospholipid syndrome, it's been called the Hughes syndrome because we have people that have described these syndromes, sometimes given their name to the syndrome, but it's basically the same thing. And so what we have, we're coming back to our antibody, so we have to have antiphospholipid antibodies, and we just want to say that the different manifestations that have been defined, now this is made up by us, by men, that we have to have some type of definition to do a classification that will fit most of the people, but there's always exceptions, so please remember that. But by consensus, the definition right now for an antiphospholipid syndrome is to have at least one clinical manifestation that's listed here, either a vascular thrombosis or an obstetrical event. And the obstetrical events are defined here quite specifically. And the presence of antibodies, and again, the antibodies that have been selected for the criteria are either the presence of a lupus anticoagulant, significant levels of anticardiolipin antibodies, or significant levels of anti-beta-2 glycoprotein 1 antibodies. Now, I say they are the ones that were chosen because there are several other antiphospholipid antibodies that have been described, that are being researched, but that have not made it up to definition for now. In 5 years, maybe this might change. We'll have to see. So what causes the manifestation of the antiphospholipid syndrome? And the next slide is very busy because I borrowed it a paper by Garcia and Dorek Erkan. But I'm just trying to illustrate the manifestations will, so if we go from the top, we have a that produces these little Y, right, the little antibodies, so they're antiphospholipid antibodies. And these antiphospholipid antibodies initially were really thought to be binding purely to a phospholipid. This is all in immunology. Usually antibodies will bind to a protein. Phospholipids are usually membranes of the cells, and they're different compounds. But it was recently found that, many years ago now, that it actually is a binding a protein that itself binds to the phospholipid. So it looked like it was a phospholipid binding, but it needed that protein. And most often is beta-2-glycoprotein 1, but it's not the only one that can do that. But the thing is, once this occurs in some individual, it can lead to different manifestations. And one of the manifestations could be more of a problem with inflammation. One can be more of a clot, which is most people will probably associate antiphospholipid antibodies with clot, but it could also be a pregnancy event because it can interfere with the trophoblast in the tissue of the placenta and of the baby that develops. So the things to remember is that there could be inflammation. It could be a vasculopathy, so when we're not sure, a pathy is basically just a disease of the vessels. It could be thrombosis, so blood clots, the protein involved with the clotting, or it could be pregnancy complications. So what does it come from? Well, the way I understand it is that it comes from a chain. And so the first thing is you're given some cards. We'll come and explain that in a moment. And the other thing is there's a chance encounter. Here you have a ram meeting another ram. He says, guess who I ran into today? This is kind of a way to think of a chance encounters. So what happens? Your cards that you're given are really your genes. And we are all have a different makeup of genes. Some genes are restricted to what the major histocompatibility complex genes. And these are genes that regulate your response to your environment and how you will defend yourself against infections, but also it's a very important field if you do organ transplant medicine because the MHC gene is important whether you're going to be rejecting a kidney that's transplanted or a bone marrow that's transplanted. Interestingly, obviously, these genes are also important on predisposition to autoimmunity. So there's a whole area of research on those. But there's also genes from other components of our genetic background that may have importance. So these will be the genes that affect the immune system. So if you have genes that can allow the cells that produce antibodies that tends to be auto-antibodies, there might be some balance here that is struck depending on how you've got your genes. Or there's several known thrombophilic genes. What I mean by this is independent of having, for example, the antiphospholipid antibodies in the syndrome, some people will have acquired from birth a predisposition to blood clots. So if you have a genes that predispose you to do blood clots alone, maybe you won't have a blood clot. But if you on top of that have also antiphospholipid antibodies that increase your risk for blood clots, that may be enough for you to then develop an event. And then we don't know, but there's quite a bit of interest now about are there protective genes? Maybe, nature is a yin and a yang. So if we have genes that make us more likely to develop autoimmunity, there might be other people that actually have gene protects them from that. And it's really the way these genes have been distributed that may allow the expression of the syndrome or not. So the first part to remember is these are the cards you're given. Okay. The summary, genetic factors are important in the development of APS. Both genes in the MHC locus and outside can have contribution. And the interaction between genetic and environmental component is going to be important. So that's the second part, the chance encounters. So let's say you have genes that predisposes you to have APS. What are other things that maybe precipitates the early events that comes with the product of the autoantibodies. And we think that infections might be one class of exposures, but also maybe many things in the environment. Everyone's very attuned to, what we breathe, maybe what we get into water. These are hypothetical because we don't have really much leads in antiphospholipid antibodies, but there's some other autoimmune diseases where silica, for example, in the minors and rheumatoid arthritis, there's some association. So there are other autoimmune diseases where environmental risk factors have been associated as a possible trigger in predisposed individual. Health habits, well, smoking is bad. We all know that for your lungs. We know it's bad for rheumatoid arthritis and for lupus. There's an increased risk of developing these conditions if you're smoking. So how does smoking, there's all sorts of theory how the smoking could be maybe a facilitator to increase inflammation and to induce a reaction, it to be seen like that as a cofactor. I don't know about here, but in Canada, everyone's big on diet. So there's all of these diets going around, the gluten-free diet, the ketogenic diet. There could be an influence. It's hard to tell. We know that omega-3 have some benefits into protecting for inflammation or vascular problem, but the science is not sorted out there. Hormones, we know pregnancy can trigger some changes, and it's intriguing that some disease like lupus in particular is 90% women as opposed to other autoimmune diseases. Medications probably cause the production of autoantibodies, some classes of medication. And obviously if you have a disease that could increase your chance of vasculopathy in your arterial circulation, anything that will increase of cardiovascular diseases can also make it worse if you have a thrombophilia. So the chain of events, the cards you're given, chance encounters, I think why it is so complex to and what causes APS is that there's more than one hit, most likely. There's a double hit or there's multiple hit. And if you go back to my little graph from the beginning, we talked about genes, we talked about the environment, B, double hit, that will first allow you to have this loss of tolerance, but it could also happen at several levels. You may have other genes and other chance encounter that will induce the production of autoantibodies. And to go to trickle disease, there might also be some double hit as well. So it becomes to be a very complex matrix to try to understand what happens at every steps. I just want to go to the next point. That was why I should not test my children for APS if I have APS. Well, first, we know the incidence, so the number of new cases of APS per certain population per year is it's estimated at 2 per 100,000 person per year. And if we look at the prevalence, which is more looking at a snapshot picture at one point in time of the whole population and how many people have APS at one point in time, it's 50 per 100,000. So these are low number. We understand we are talking about a rare disease. In lupus, because I'm not sure we have the numbers in APS, but in lupus, if you were to test all first-degree relatives, so children, brother, sister, or parents, so first-degree relatives, and test them for antibodies for lupus, the anti-nuclear antibodies. Up to 25% of people that are first-degree relative, they do not have the disease, will turn out to be positive for this antibody. But in the great majority, that will never lead to having a disease or expression of a disease. And in fact, if you test a blood bank, all donors, for anti-nuclear antibodies, you'll have 5 to 8% of the general population with positive anti-nuclear antibodies. Now, there are a few things that increases the risk of an anti-nuclear antibody without, or an autoantibody without having disease. Age, as we age, the proportion of people with these antibodies increase. And it may just reflect the experience of our immune system having been exposed more and more to different events in their life. being female is increasing also the risk of having autoantibodies. But if we look at these and we think that up to 25% of first degree will have an antibody, and the consequences of being labeled with having a positive antibody without having clinical disease, well, first on your personal life and your quality of life. I come from a family with hyperlipidemia, and when I was 10, I was tested for hyperlipidemia, and guess what? I had type 2A hyperlipidemia. Well, it's marred most of my childhood because I could think that, by age 40, I probably would have a heart attack, and I started taking pills. I have to hold on this terrible diet, I tell you. And so, I can relate to the idea of being very careful in wanting to test children, offspring for that. Insurance purposes also, you may be sick and you may be denied life insurance because you have a positive antibody. So these are consequences that are not trivial and that are important to consider when you look at this. It's different if someone develops symptoms. That would be a different issue. But we have to be very careful about the symptoms and making sure we're doing the right tests at the right time for the right reason. The other thing about testing for positive autoantibodies, I lost that point. Sorry. Yes, I think I've gone over that. So, just to review, I wanted to give you an idea of what the path to autoimmunity was, and I used the example of the Enigma machine because I find it's very relevant to us. And unfortunately, unlike Turing, we haven't solved the problem. Hopefully we will. I've mentioned that APS is a syndrome. The disease makes it more difficult to study because we have to rely on definitions. And also in the clinical world, because I see patients every day, I have patients refer to me. Oh, I know the point I wanted to make. So I see patients every day, and one of the main reasons for consultation is this person has anti-phospholipid antibodies because they had a pre-op assessment with prolonged INR, and then, what do you do? In fact, in my practice, this patient has a positive anti-nuclear antibody. Do they have lupus? And in Canada, there's a movement about the medical association that's called Choose Wisely. So how do you decide to do a test on someone or not? And the rheumatology group out of Canada have decided that doing an ANA, an anti-nuclear antibody, is the first thing you should not do unless you really have good reason to do that test, because it generates 2 false positive tests. 5 or 8% of the population is positive. Lupus is 1 in 2,000. So you can imagine the number of consults that could be generated and the anxiety that goes about it with having this test done. It's parallel for antiphospholipid antibodies. We went over what causes the manifestation of APS, so everyone's given some cards, and these are your genes, your predisposing genes, or maybe your protecting genes that we know less about. Then you have your chance encounters, and that is very difficult to prevent. And then I reviewed why I should not test my children for APS. So I'm going to take questions, but I just wanted to add a few slides for this afternoon because I'm going to be chairing the last session this afternoon with you guys. I'll be here all day with you, and please come and talk to me. But I have a few questions I have for you, and I'll develop them at the beginning of the sessions. But I just want to talk about, keep that in mind, a sliver. What am I talking about? I'm not telling you now. I don't know if your system looks like this, but this is what it looks like in Canada. So if you have a problem with AP, we are sent into all of these different specialists. Your family doctor is lost in the middle, and usually you cannot access we have a universal healthcare system, but it's very difficult to have services of physiotherapy, counseling, social worker, nutritionist, very difficult. Jane Austen, we have all a better guide in ourselves if we would attend to it than any other person can be. I want to talk about activation of patients. And I'm going to leave you with that, which is a computer screen. And I'll come back this afternoon with those. Now, instead of lupus, it could be APS. And these are my support. Thank you.
So, we've time for a few questions. Does anybody want to ask Paul anything?
First of all,
can you just maybe introduce you and where you're from, and I will get you a microphone. Here's a roving microphone. There's just the acoustics are a bit flatter.
Singing's good.
Hello.
Hi.
Right, okay, I just wanted to ask, in regards to the why I shouldn't test my children, so I've had multiple PAs and I've got 3 daughters, and also in that stat you said about how 90% of lupus patients are female, and obviously the risks associated with pregnancy and APS as well and everything else. And so that's a real quandary I have about whether or not to test my children, because I don't want to unnecessarily worry them, but equally I've got 3 daughters and I worry about them going on the contraceptive pill and having pregnancies in the future. Don't want them to go through what I'm through. But now you're sort of slightly changing my mindset on that. So I just wondered, is there any statistical data whatsoever that gives me any sort of real risk factor on what are the actual chances of them or their children? What is the genetic predisposition? Have we got, is there a percentage? I don't know, 5% of patients with APS have a relative or anything like that. Because I know, with lupus, you said 25% of first-degree relatives have at least an auto antibody, but not necessarily the disease. So the predisposition is lying there in the family. Mm-hmm. So there's clearly a very clear genetic link, whether or not you get the disease or not. But do we actually have any data on that? And also, the women being more likely to have APS, is that really a thing, or is it just because pregnancy heals it?
Okay, I'll answer maybe the second one first.
Go for it.
In autoimmunity, it's not only lupus or APS, there's a predominance of women. In APS, you would think maybe because of the pregnancy story, it could be detected more often in women. But in lupus, it's not the case. And it's interesting that if you go by also age groups, there's differences. So if you go, because there is childhood lupus, and in childhood lupus, the ratio is much less. So between the age of 20 and 40 is about 9-to-1. Female to male, but in children it will go down to about 3 or 4-to-1, and then after menopause it's back a little bit, like more 6-to-1. So there seems to be a hormonal effect or something happening during the years that you have possibility to reproduce, but we still haven't understood exactly how. There's some effect of hormones on the immune system, and maybe that's how. Pregnancy, you do have to be tolerant, because you have to be tolerant to your child, which is different makeup into the immune system. So is it related to that? Unknown. So I don't think there's a bias in terms of having more female with autoimmunity just because of the pregnancy. I think it's beyond that. Now the first question obviously is very difficult, and it doesn't only hinge on APS. Now we're talking about an individual, right? It's easy to make recommendations for a population, right? Don't test for ANA, but in an individual, you have to factor a few things, especially if it's pulmonary embolism or blood clots, because is there a family history? Was there other people in the family? Are there other risk factors? That double hit theory, and some of other risk factors, were they inherited, were they genetic risk factors? And there are known entities like the factor V Leiden mutation or the prothrombin mutation, and there are probably others that we don't even know about. So that's why that family history will be important. And then you probably would have to sit down with hematologists, because they're usually the one dealing even more with blood clots world, and try to assess for your family, is it relevant or not to do the testing. Well, one of the issue about the autoimmunity, the problem is we have made family trees of people with lupus, for example, and you often will find other autoimmune diseases, but they're not necessarily the same. So you could test, your children for an antiphospholipid antibody, but it may be irrelevant. They might hopefully we'll never develop any other things, but we know that there's an increased risk in families to have autoimmune disease manifestation, and it may be rheumatoid arthritis or it may be diabetes in the child, but they're usually very extended trees and you see them quite far apart. So at this point I don't have a number for you because I think it's an individual assessment that probably would be best done with a hematologist there are genetic counseling also sometimes, but since this is not a genetic disease, you're not going to client for us, it's 2 years waiting list anyway to see a genetic counselor, I don't know here. So I think it would be best with the hematologist. So I cannot come up with a number.
Okay, so one more question before the tea break. You got
Professor Paul, my name is Sasha. In February 2016, I was diagnosed with mild lupus on the basis of the blood test and Raynaud's syndrome. And I'm taking 200 milligrams of hydroxychloroquine, no clinical other manifestation. In the winter, I feel more fatigue and muscle pains, but some are pretty much perfect. In January this year, I was diagnosed triple positive for antiphospholipid antibodies at St. Thomas and Guy's Clinic in London. In the private lupus clinic run by the Professor Graham Hughes, I've done tests twice, and on both occasions I was completely negative on all 3 antibodies. But on the NHS clinic, on the lupus, which I mentioned earlier, in January I was triple positive, then in April, 3 months after, I was positive only on 2 of them. So my rheumatologist put me on a baby aspirin as a precaution, and my hydroxychloroquine was into 400 milligrams. So my first question is, should I be put on heparin as a precaution because I'm a triple positive? And is this a progression of my lupus that I didn't have the antibodies previously, phospholipid antibodies? And also having a varicose veins, sorry, it's like pretty much 3 questions. It does increase my risk of having a thrombotic event because I have a varicose veins, because I've been seeing also vascular surgeons in terms of should I remove the veins to lower the risk of thromb. Thank you very much.
Okay. I should have taken notes. Again, the last question first. Obviously, this is the double hit question, right? Do you have other reasons? Like if you take a plunge trip by plane, obviously if it's beyond 5 hours, that could be enough to trigger an event if you have a predisposition. So I think varicose veins, I guess it depends on the severity of your varicose veins and whether you can manage them just locally rather than surgically. Because we'd rather not often interfere with procedures in the vascular tree if you're at risk of having problems for blood clots, right? The second question was heparin, and I certainly don't think you need heparin for prophylaxis, right? It's different if you've had an event, and right now you haven't had an event. And the first question is this an evolution of lupus? When they look at the army, there are people with lupus, they also look after that first year, up to 5 years after. It was rare that people would add other autoantibodies. When they've reached an average of 3 autoantibodies, including possibly the antiphospholipid antibodies in lupus, and they would not develop new autoantibodies. Now the problem, and we've been plagued with this at this meeting, and we always are talking about, is the differences between assays. And some assays will be positive, and you do it in another lab, but it's a different assay, and it becomes negative, and then the levels change. So what is true fluctuation over time, that may be real, or what is just due to the lab, to the kits that are being used, and that's a problem, and the quality controls, and that's a difficult point. We obviously pay more weight if you have triple positivity that's been documented at least twice, at least 3 months apart. But even double positivity, I think, are significant. But the aspirin is a recommendation, but it is not unanimously accepted. There's no guidelines right now that would say, you need to take an aspirin just for positive tests. Plaquenil, well, you have a good reason to be on Plaquenil from lupus indications, from what I understand, and there probably is some benefits on the vascular tree. Even in lupus that do not have antiphospholipid antibody, Plaquenil has been shown to decrease the risk of having an event in the vasculature. That part, I think, is quite reasonable.
Excellent. Okay, so it's now just about 11:15, so I thank you very much, Paul. So what I probably do is we have a break for coffee, and come back. We were meant to start the second session at 11, but we'll come at 11:15. And if you come back at 11:15, and we'll make up a little bit of time, and we'll see you back in about half an hour. Thank you.